No voice, Vanessa.
So, good afternoon for all our attendees from all over the world. So, on behalf of CRG, Dr. Fadi Farahat, and myself as representative of AMAC, it's our pleasure to announce the start of ABC courses for 2022. As you know, all these activities are accredited by AMAC with 2 CMEs, and it's approved by ASCO and UICC. Our first activity will be about breast cancer module, receptor positives, HER2. So I will present our first speaker, Dr. Tahsin Al-Rubay'i, to start with the case presentation. The floor now is done for all our chairpersons, moderators, Dr. Lalla Kawthar from Morocco, Dr. Hussein Sabbagh, and Dr. Haidar Nu'man. So please, Dr. Tahsin, the floor is yours. The voice is weak.
Thank you very much.
We don't hear the voice, Dr. Tahsin.
Vanessa.
Yes, doctor.
Are you hearing the voice?
No, the internet was cut at Dr. Rubai's end.
Let me Laken, meanwhile start by going for this quiz, okay? Okay, please, Vanessa, can you send a message? Dr. Tahsin will start and he will join us. Okay, thank you guys for this opportunity.
Sorry, doctor. Dr. Tahsin is with us.
Yalla, okay.
So thank you very much. Can we start right now?
Yes.
Yeah, thank you. So our first case for today is Amira. She is 39 years old, sport fanatic. In 5 years' time, she had run 4 marathons, completed 1 triathlon, and she was recently diagnosed with right-sided breast cancer. Now, in her assessment summary, she is a premenopausal lady, ECOG performance status of 0, no relevant medical or family history of breast or ovarian cancer. She had clinically T1C, clinically N0, triple negative breast cancer, Ki67 45%, grade 3 basal-like. Her CT scan, chest, abdomen, and bone scan actually was negative, so she got clinically T1C, clinically N0 and M0 disease with no BRCA mutation. Next. So the question is, What option would you choose for this lady? Primary systemic therapy and mastectomy, primary systemic therapy and breast conserving surgery, or primary bilateral mastectomy? Could you please vote?
The voting system is not taking the answer.
Vanessa?
Yes, doctor, we have the answers, but the panelists are not
Okay.
allowed to answer. Only
Okay.
attendees.
Okay.
So good. Now, a very good percentage have voted for primary systemic therapy and breast conservative surgery. And this is actually very, very interesting case because this patient is a very young lady. She's a very fit one. And of course, we are trying to start her on primary systemic treatment and allowing for breast conservative surgery. Case number 2, Nell is a 51 years old airline pilot. She felt a lump in her right breast and was diagnosed with breast cancer. She is a postmenopausal lady, ECOG performance status of 0, with no relevant medical or family history of breast or ovarian cancer. She had clinically T2, clinically N0. Again, she had triple negative breast cancer, KS7 26%, grade 2, and basal-like. Her CT scan, chest and abdomen, and bone scan was negative, so she had clinically M0. She received primary systemic therapy, EC by 4, followed by weekly paclitaxel by 12, mastectomy and sentinel lymph node biopsy deemed the best strategy based on tumor and breast size, R0 resection. Pathologically, YPT2 and 0, grade 2, and lymphovascular space invasion is absent. Next. Could you please go back? So the best option for this lady would be postoperative radiotherapy of the chest wall only, postoperative radiotherapy of the chest wall and the nodal region, or just we have to follow this patient with no radiotherapy. Could you please vote?
Maybe we have to ask people who voted differently, Dr. Tahsin. What do you think?
Sure. Yeah. But يعني unfortunately أنا ما دا أشوف الvoting yet. Dr. Fadi, this is the Iraqi tradition, يعني electrical shutdown.
No worry. We live in the same conditions. So, Dr. Tahsin, people were mainly voting for the option B and C, 40,
Yes.
تقريباً 40-40. So,
yeah. So the question here is actually that we should address that why we choose, for example, for the audience, is to go for postoperative radiotherapy for the chest wall or the nodal region as well. Don't you think that this patient is having only T2 and 0 disease? So what's the idea behind that? Anyone from the audience? Hello?
Any suggestions? I'm afraid, Vanessa, people are sending, saying that the voice is low, صوت واطي. Can you do anything for that? مع انه انا سامع كثير منيح.
وأنا كمان.
So if there is no answer, no comment, maybe
No, it's okay.
you contribute.
We can contribute actually that this particular lady, she was having clinically T2, and when we started her on neoadjuvant treatment and primary systemic therapy, I mean, for AC and 12-weekly paclitaxel, she's still having pathological T2. She's having also triple negative breast cancer, despite the fact that her Ki-67 is in the range of 26. So definitely, I think that there is no response for the primary systemic treatment. So still actually post-operative radiotherapy is a good option for this lady. Next. Now, this is the most important question in the era of CDK4/6 inhibitors. Now we have, could you please go back again? Which of the following CDK4/6 inhibitors have a phase 3 clinical data informing their efficacy and safety as adjuvant therapy for a patient with a high-risk hormone receptor positive HER2 negative early breast cancer? Is it palbociclib and ribociclib, abemaciclib and ribociclib, abema and palbo, abemaciclib only, palbociclib only? Could you please vote? So a good percentage of the voters have chosen abemaciclib only. Now, if we go to the CDK4/6 inhibitors was first actually approved in the management of patients with metastatic breast cancer who have hormonal positive, HER2 negative advanced breast cancer. Now, what's interesting is that they do have a real activity in the metastatic setting. Now, when it comes to the adjuvant setting, there was an argument, how could these agents prove to be actually effective in the metastatic setting while only one of them had an approval actually in the adjuvant setting? We know that abemaciclib was approved based on the Monarch E trial, and that it was approved in the context of addition to the adjuvant hormonal treatment in those patients who are having a high-risk early breast cancer. Next.
Dr. Tahsin, shouldn't we mention that the data
Yes.
of palbo till now
Still,
was negative, while
yes, it was actually, it was negative after neoadjuvant chemotherapy in the Penelope trial, and as well as in the Palace trial.
While ribo is meanwhile pending.
Yes, awaiting the results of the Natalie trial. Next slide.
Vanessa, we don't see the screen, the presentation.
Okay. Question number 4. What is the approximate median overall survival of metastatic breast cancer? Is it 2 years, 3 years, 5 years, or 7 years?
Guys, it's challenging. Yalla, let's vote لأنه
Yes.
I am not sure the vote here will be adequate. يلا. Like introducing people to the metastatic setting.
Yeah. So it seems that we have 3 years and 5 years. Very interesting, actually. Now, 42% around, they vote for both 3 years and 5 years. Now, this is very, very, very interesting, actually, question, because we know that the approximate median overall survival for those patients is approaching actually 3 years. However, there are around 20 to 30% of women who have metastatic breast cancer might live up to actually 5 years. So this is the very, very actually, it was a very challenging question. Next slide. And this is actually the rationale behind which is that according to the MBC decade report, the progress in terms of improved outcome, quality of life is awaiting actually some recent studies.
Dr. Tahsin, if I can make a comment,
Yes.
just the answer we have to say to the attendees that the right answer is the B answer. So the
Yeah.
median overall survival is 3 years.
3.
And we
Yes.
are confounding with the fact we are saying 5 or 10 because we have some patient, as Dr. Tahsin said, living more than years up to 5. So it's really 40. It's really the second answer. And I would like to tell you that you guys answered better than that was been done, because it's a questionnaire taken from other sides, and on other side they said that the 3 and 5 years are 36%, 36 and 35%. So you today did better than the Western doctors answering these questions. Felicitation, congratulations.
Félicitations. Now, which imaging studies may be used to identify non-axillary lymph node metastasis in patients with breast cancer? Is it MRI, ultrasonography, or PET scan or scintillammography? Now, around 21% voted for MRI, and a good percentage, actually around 72, have voted for PET-CT scan. Now, let us tell you this story, that the combination of PET and CT scan is very important in recognizing and staging those patients actually with early and locally advanced breast cancer, in order to detect whether there is an internal mammary lymph node or there is an axillary or a supraclavicular actually lymph node. However, it's very important again in those patients with inflammatory breast cancer in order to stage those patients as having metastatic disease or not. So I totally agree with you. PET-CT scan is used to detect the non-axillary lymph node metastasis. Next. Vanessa. Hello.
Vanessa, are you with us?
Yes, Doctor.
Yes. So The next question is a very important one with respect to the metastatic setting and the reassessment of biological markers in the metastatic setting. First of all, biological markers, especially hormone receptors and HER2, should be reassessed at least once in the metastatic setting if clinically feasible. Then, or biological markers, especially hormonal receptors and HER2, should not be assessed in the metastatic setting, or biological markers, especially hormone receptor and HER2, should only be reassessed in the metastatic setting when considering a switch to an anti-PD-1 agent, and biological markers, especially hormone receptor and HER2, should only be reassessed in the metastatic setting when the patients are taxane naive. Could you please vote? Very interesting. 73% have voted that the biological markers, especially hormone receptor and HER2, should be actually reassessed at least once in the metastatic setting. Now, this is a very important question. Knowing that breast cancer is a very heterogeneous disease, so we should actually think about this heterogeneity. Now, at first, when we are doing an assessment of the biological activity of the disease, we are doing hormonal receptor and HER2. And so if these hormonal receptors tend to be positive and HER2, for example, tend to be negative, and then the patient is going from one stage to another and develop a metastatic disease, for example, hepatic metastasis or liver secondaries, then definitely we have to look at the discordance between the primary and the metastatic setting, because at that time, around 1 in 6 of those patients, at least 15% of those patients might have a change actually from a hormone receptor positive to a hormone receptor negative, or from a HER2 negative to a HER2 positive disease. So this is a very good actually question about the discordance of the primary and the secondary in the breast cancer. Next slide. Next. Back again, please, to question number 6. Okay, which is correct regarding the reassessment of biological marker? Sorry, this was already mentioned. Next. Now, which is routinely recommended as first-line treatment of hormone receptor positive metastatic breast cancer? Is it chemotherapy, endocrine therapy, combined chemo and endocrine therapy, or is it immune therapy? Please go ahead. So around 52% have voted for endocrine therapy alone. And unfortunately, a good percentage have actually voted for the combination of chemo and endocrine therapy. And around 11% have voted for chemotherapy. Now, let's go for the guidelines, actually. Now, we know that those patients who are having hormone receptor positive disease in the metastatic setting, the guidelines are stating that we have to start with endocrine therapy in the first-line setting unless actually there is a life-threatening complication, or there is actually an extensive visceral crisis. So definitely the option is go for in the metastatic setting from one endocrine treatment to another endocrine treatment. However, chemotherapy should be done whenever there is actually a very painful, extensive bony metastasis, and so on. So I think that the good option for those patients with hormone receptor positive in the metastatic setting is to go for endocrine treatment. Next. Next, please. Now, which statement about therapeutic options in metastatic breast cancer is accurate? Combination cytotoxic therapy is the preferred approach. Cytotoxic therapy is not employed in metastatic breast cancer. Single agent sequential cytotoxic therapy is preferred, and cytotoxic therapy is only employed in ER/PR positive disease. So here we have single agent cytotoxic therapy is preferred, and that was actually voted in around 43%, and around 36% have voted for the combination cytotoxic therapy. Now, just have a look at this question from the following point of view. Now, we all agree that single agent sequential cytotoxic therapy is preferred in those patients in the therapeutic setting in metastatic breast cancer. Now, why? Because first of all, we are going to use every line. And secondly, if you are going to use the combination cytotoxic chemotherapy, it wouldn't add much actually in terms of response. However, it will add much in terms of toxicity. And again, if it is not employed actually in ER/PR positive, however, cytotoxic chemotherapy can be used and employed actually in a triple negative breast cancer rather than in ER/PR positive disease. Next slide. Now, Louisa is a 58 years old interior decorator with a primary metastatic breast cancer 17 months ago. Her ECOG performance status is 0. She's a postmenopausal lady, no relevant medical or family history of a breast or ovarian cancer. She was diagnosed with a primary metastatic breast cancer 17 months ago. Imaging is showing 5-centimeter tumor in the right breast, 4 suspicious axillary lymph nodes, multiple suspicious lesions in the bone and the pleura. Her tumor biology is showing NST, ER 90%, P progesterone receptor 70%, HER2 negative, and a grade 2 disease. Next. Now, treatment was started with letrozole and CDK4/6 inhibitor 1 month after the diagnosis, and very nicely, a regression of the bone and the pleural metastasis took place 5 months later. She had stable disease after 6 additional months. Next. So 5 months later, 16 months meaning after the start of letrozole and CDK4/6, she had pleura, stable disease, bone progression, liver is showing new metastasis. Now, biopsy of the liver metastasis is still showing ER 70%, progesterone receptor 40%, HER2 negative, and grade 2 disease with a somatic PIK3CA mutation status is a mutant, germline BRCA mutation status is a wild time. Next. So this is a very important actually question. The question is, are you going for alpelisib plus fulvestrant or PARP inhibitors, olaparib or talazoparib, exemestane plus everolimus, or fulvestrant alone?
Yalla, very nice, Dr.
Very nice. Alpelisib plus. So let us go to the next slide, and we will discuss the trial itself. Next. So this is a very important question in terms of that this lady in the metastatic setting, she's having PIK3CA mutation. So SOLAR-1 trial looking at alpelisib plus fulvestrant for men and postmenopausal women with hormone receptor positive, HER2 negative advanced breast cancer who is progressing actually on or after aromatase inhibitors. So these are actually the eligibility criteria. Those patients were stratified according to the PIK3CA mutation into mutant and non-mutant, and then they took the mutant cohort and they randomized them in a 1-to-1 fashion into alpelisib 300 milligram QD and fulvestrant 500 milligram IM plus versus placebo plus fulvestrant, and the non-mutant cohort again into alpelisib fulvestrant versus placebo plus fulvestrant. They looked at the primary endpoint, which was a progression-free survival in the PIK3CA mutation cohort, which is locally assessed. Secondary endpoint was overall survival in the mutant cohort, PFS in the non-mutant cohort, PFS in the mutant, in the circulating cDNA, and overall response rate, and so on. Safety, of course. Next slide.
Dr. Tahsin, we have a presentation on the PIK3CA.
Yeah. So this is the only, the last slide, that the progression-free survival actually was showing much better in the alpelisib plus fulvestrant versus placebo plus fulvestrant in the PIK3CA mutation. And that was actually the basis for the very good actually chosen alpelisib plus fulvestrant for this lady. Next. So I think I will leave this study to Dr. Fadi Farahat in the next. I think Dr. Fadi, we've passed through all the quizzes, right?
Yes, all the questions.
So thank you very much, and we will continue with our moderators and our chairman. Thank you.
Thank you, Dr. Tahsin, for the excellent cases. So now the floor is for Dr. Lalla Kauthar and Dr. Hussein, I think he is from Syria, to present our next speaker. Please, Dr. Lalla. They are not with us. Dr. Lalla.
Hi.
Hi, Dr. Lalla. The floor is yours now to present the next speaker, please.
Yes, okay. So it's my great pleasure to introduce Dr. Fadi Farhat, which is a professor of medical oncology and the head of the Department of Hematology and Oncology in the university in Hamoud Hospital, UMC University in Lebanon. Dr. Fadi, the floor is yours.
Thank you, Dr. Alala. Dr. Alala joined us directly from the clinic. Merci beaucoup. This presentation should be done by Dr. Sana Al-Sakhan, who apologized for the last minute because of her, she's now member of the chair committees of ASCO, and she's in USA for that. So we wish her excellent luck. Can I have the slides, please? Okay, so I will present, let me share my slides, no? Okay, thank you. So further progress in expanding treatment options for hormone receptor HER2 negative. What are our choices? Can I have the yes, thank you. So I will be, okay. So I will be talking about the most actual and important new pathway, the PIK3CA mutational pathway, the PI3K ACT-mTOR pathway in breast cancer. I remind you that this slide was presented by Dr. Vanessa. انتوا عم تعملوا شيء بالسلايدات؟ انا I can do it. Okay. Okay, thank you. So the SOLAR one unfortunately didn't show an overall survival benefit, but the PFS was significant, and the progression-free survival was almost doubled. And just to remind you, the PI3K pathway, the PI3K pathway, the PIP2 should be phosphorylized to PIP3, and this will stimulate the downstreaming pathway, like to the ACT and others. And as you can see from the PI3K, will be downstreaming, stimulating the ACT, then mTOR, and then stimulating the CDK. But remember well that there is other parallel pathways like the insulin growth factor, and specifically and the most important, the ER pathway, estrogen receptor pathway. So there is a communication between these two pathways. How frequently do we have alteration in this pathway? How frequently? The PI3K ACT-mTOR pathway is upregulated in many tumors, as you can see here. So soon we will have a launch, we'll be launching, there will be a launch of the PIK3CA inhibitor in hemato, in lymphoma, for example. But we can find it in glioblastoma, melanomas, ovarian, and other. So it's a frequent mutation in different tumor. And remember that all these pathways are important for survival of normal body. And remember also that this transformation or from phosphorylation from PIP2 to PIP3 or vice versa is really important for the body, but it might also involve in cancer development. And also you can see later that the phosphorylation of the ACT will be the next step after the mutation of the PI3K pathway and the PIP2, PIP3 phosphorylation. And then after the activation of the ACT, as you can see here, will lead to the mTOR stimulation. So as you can see, this is the pathway leading to stimulation of mTOR1 and mTOR2. But remember that the P10 is important to inhibit the ACT activation. That's why we call it a tumor suppressor gene. This why when you have in a genomic profiling analysis a P10 absence or alteration, this means that we are losing the tumor suppressor gene, which means that the cancer might be either more aggressive or this pathway will be more active. So remember, the P10 is an inhibitor for this pathway, and it plays an important role. And as I said, when the P10 is inhibited, the ACT-mTOR pathway is stimulated, and then the stimulation of the growth of the mitosis transformation, etc., will be active. So what about the PI3K pathway alteration, specifically in estrogen receptor positive breast cancer tumor? We know that the dependence of the PI3K pathways occurs in different way. Remember, again, this is the pathway. I'm sorry, just a second. This is the pathway. As you can see, it will depend from many lines. It will depend from the ACT, as you can see here. So any stimulation of the ACT, because it's down in the pathway, if the ACT is stimulated, so the pathway is stimulated. If the P10 is lost, the pathway is stimulated. If the receptor of the tyrosine kinases intrinsically or extra, the pathway will be also stimulated parallel. So any stimulation of the insulin growth factor, FGFR, HER2, might also stimulate these pathways. And remember also that we might have some kind of mutations which is rare of the RAS, and we can have also some rare, very rare type of P10 mutation acquired or others, and also this might help to the development of these pathways. It's just to show you that even if we have a PI3K inhibitor or mTOR inhibitor, there is many collateral that might help in re-stimulating the PI3K pathway. And in breast cancer, it's a frequent a mutation, about 40%, and we have different type of mutation. Remember that it might be important. Okay, and what's the outcome of this mutation? We know that in the SAPHIR-02 trial by Andre, there was almost 650 patients. It was a prospective phase 2 trial, and the genomic profile was available. The biopsy of metastasis showed, as you can see, liver 44, lymph node 20%, breast 16, etc. And when we look to the response rate to chemotherapy, according to PIK3CA mutation, which is important to understand the prognosis of these mutation, you can see that in the HER2 negative breast cancer, hormone positive, the presence of mutation showed a difference if there was a PI3K mutation or not. In the wild type, the response is different than the PIK3CA, while in triple negative, it was also different. And here we can show that for the PI3K mutated, the outcome is worsening, okay, as you can see in the HER2 negative hormone positive, while surprisingly, the PIK3CA mutation, PI3K mutation in the triple negative is a good prognostic factor. So again, in the luminal A, luminal B, if we can call them like that, you can see that the PIK3CA, PI3K, PIK3CA mutation is a bad prognostic factor, while it's a positive prognostic factor in triple negative breast cancer. And it's amazing, we can use this for later on. So this was said as the conclusion. Remember, PIK3CA in the triple negative might predict a good response to the treatment. Now, again, I will go to the importance of this this pathway. Again, I insist it's very important, and look how this pathway will crosstalk with the estrogen receptor. So now we understand why when everolimus was designed to inhibit the mTOR, it was not enough. It didn't work as monotherapy. Why? Because the crosstalk allowed the ER pathway to reactivate the mitosis or the cancer growth. So if you inhibit only the pathway when there is a crosstalk, the parallel pathway will take the lead and will stimulate the cell. So that's why when they used the everolimus, the mTOR inhibitor, and they added an anti-estrogen or anti-aromatase, when even if it was used before and resistant for that, we could reach a good response, which means that when you act on the mTOR and you inhibit it, you can regain or overcome the resistance to the previous anti-ER treatment use. And this is very important. Okay, I cannot move the slide. So, yeah, it's the same. I've already presented this data. And remember that the PIK3CA also has a crosstalk with the androgen receptor in the prostate cancer. So just to mention it, and the Bolero phase 2, we said that there is an improvement. And estrogen receptor upregulation in the PI3K inhibition was used as a background to the SOLAR-1 trial. So knowing that you have to inhibit the ER pathway and the PIK3CA, PI3K ACT mTOR pathway, the first step was to try the mTOR to inhibit the ACT is now ongoing, and the SOLAR trial tried to inhibit the PI3K by itself, and the PFS was improved indeed, as I said previously, almost double, which is really good in estrogen resistant tumor, in breast cancer resistant tumor to hormone. So just to go quickly again, we said that everolimus, temsirolimus were approved as inhibitors. We don't have the temsirolimus in our region. We have the everolimus. We are using it. Personally, I'm using it a lot. It was the Bolero trial again, and it showed an improvement in PFS, a significant improvement. And you can go then after to the competitor of mTOR. It's under development. And just to say that, again, we are acting on this pathway. And also, what do we have? We have the dual blockade of ER-PI3K, which might be effective. We have here a dual PI3K and mTOR inhibitors, some different names of different drugs on ongoing research. And finally, I will go to the PI3K inhibitors. We have a pan-PI3K inhibitors, that is the buparlazib and others. And this trial was not really impressive, despite the fact that the PFS was positive. I go back to the BEL trial, BEL-2 trial, where the pan-PI3K inhibitor, what does it mean pan? It inhibits the alpha, beta, gamma, delta. So it was shows an improvement, but there was a lot of toxicity. So it was considered as clinically non-significant. And as you can see, they tried then after to get an inhibitor only for beta, and apparently it worked. And the results were interesting. Was also capivasertib, with the capivasertib. I don't know how much we will still continue to learn, because this one was an ACT inhibitor. Again, from mTOR or for PI3K, we have an ACT inhibitor. So if you inhibit the estrogen pathway and the PI3K via anyone, here it's the capivasertib, which is AstraZeneca product, you see that the inhibition will lead to an improvement on the PFS and hazard ratio of 0.58, which is important. So what's the take message from this presentation? We know very well that actually nowadays the PI3K ACT mTOR pathway is important. It's a major intracellular signaling pathway. It's regulating cellular function, normal cellular function. Any disruption in the function, any mutation, any upregulation will lead to a tumor proliferation. And we know that this is present as upregulation in 70% of tumors. And remember, the crosstalk between the ER and the PI3K is important. And also remember that the PI3K, the PIK3CA mutation might occur in different way. Remember also that another enzymes may play a role, the ACT, the FGFR, the HER2, and specifically the PTN, where the loss will induce a stimulation of the pathway. And finally, remember also that in triple negative, it's good to have PIK3CA mutation. In hormone positive, it's not good. I mean, in the sense that the prognostic is worse, while in the triple negative, it's better. And if we target this, we might have a control of the disease. And finally, we have different way to make a blockage by a combination of different inhibition or inhibition on different level. And the alpelisib till now is the most advances in the development of the PI3K ACT-mTOR inhibition pathway. And the data are robust, but probably we need to have something with more results and probably with overall survival benefit. With that, I finish and I leave the floor to Mr. and Mrs. The moderators, chairmans. Thank you very much.
Lalla.
Dr. Fadi, thank you very much for your presentation. I'm sorry for this, for being late. Actually, in Morocco, it's 6 p.m. and we're still working with the patients in the clinic. So it's a great pleasure to see you again after this period. I have a question for you, Dr. Fadi. Do you have access to alpelisib in your region?
For the alpelisib, yes, we have a compassionate program, and we already included many patients in this compassionate pathway, let's say. And also we participated in the SOLAR trial. So we had some patients in the SOLAR trial that were included in Lebanon, and my center also one of these centers. So yes, you are using the alpelisib either as compassionate, or in some cases, they might brought it from outside, and we have used it in the trial.
Okay, actually in Morocco, some patients have access, but they brought it from France or from Spain. And I have a personal experience with one patient under alpelisib, and actually the tolerance was really tough. I don't know, maybe you have more patients than I, and you can give us some advice, because the tolerance is really tough to manage.
It's good. Maybe we have to do something on alpelisib, because yes, indeed, it might be tough, but it might be well controlled. The rash might be controlled proactively by giving a treatment. You know very well that we cannot include patients before controlling the diabetes status. So if the HbA1c or FBS are high, you should not include your patient. And with a good monitoring and proactive follow-up, you can overcome these hurdles, if I can, these obstacles. And I know it's maybe your first patient like that, but you can manage it. And in oncology, we don't like drugs with no toxicity, and we don't like drugs with a lot of toxicity. So you will learn how to deal with it. It's not really impossible. It's really possible if you do it, if you prepare yourself. proactively.
Okay, thank you very much. So it's always about training. Actually, I have one comment in the questionnaire. I was really surprised by the percentage of doctors voting for chemotherapy for HR positive breast cancer. I mean, we are still at this point, despite all the guidelines and the studies advocating the use of endocrine therapy for HR positive breast cancer, many doctors are still prescribing chemotherapy for metastatic breast cancer HR positive.
Yes, you're right.
So are there other questions? Other panelists?
Dr. Haider Nauman is with us, no? He was with us as panelist.
Yeah, he was with us now.
حبيبي دكتور فادي كيفك؟
تحياتي واشواقي.
الله يسلمك حبيبي مشتاقين لك.
طول عمرك. يلا soon you will be making comments with Dr. Basim Youssef on radiotherapy.
إن شاء الله. Okay, إن شاء الله.
Yeah, Dr. Haider, would you like to present Dr. Youssef?
I know him personally, Dr. Youssef. He's one of the landmark oncology, clinical radiation oncologist. He's graduated from AUB, as I remember, and he's now head of department of the radiation oncologist in the AUB.
Actually, not had yet, not had too early. Thank you, Dr. Haider.
Yeah, inshallah soon, inshallah soon.
Dr. Haider means that's our feeling.
Dr. Basim Kamran.
Thank you for the presentation. Good evening, everybody.
Yeah, Dr. Youssef, the floor is yours.
Okay, I'm sharing my screen now. Can you see it?
Yes.
Okay, so the topic of my presentation tonight is internal memory irradiation in node-positive breast cancer. This is the outline of my presentation. I'm going to start with a quick introduction, and then we will move to discuss the indications for adjuvant radiation therapy in breast cancer. Finally, we will move to contemporary studies on internal memory chain radiotherapy. And then we will discuss management of clinically involved IMC lymph nodes. And before concluding, I'm gonna present internal memory chain radiotherapy techniques.
دكتور باسم ممكن نسويها فول سكرين؟
Oh yes, sure. يلا لحظة. Okay, I think now it works. All right, now radiation therapy is a standard treatment in the adjuvant setting for invasive breast cancer. So for patients who undergo breast conserving surgery, we actually use it for almost all of the patients. There are a few exceptions that are mainly in elderly patients with early stage luminal A disease. Otherwise, we treat all the patients after partial mastectomy. Obviously, we treat patients with node-positive disease. Now, for those who have underwent modified radical mastectomy, the indications are advanced T stage, like T3 and T4, node-positive disease, and positive margins. Now, for patients requiring adjuvant locoregional radiotherapy for node-positive disease, the treatment fields include the breast or the chest wall, the supraclavicular lymph nodes, plus or minus the internal memory chain lymph nodes. So if you look at the picture, the location of the IMC lymph nodes is almost at the midline. It is lateral to the sternum. And the most commonly involved sites are the first three intercostal spaces. Now, the need to treat these lymph nodes has been a matter of debate in the radiation oncology community for decades. for a couple of reasons. The first one is that there is conflicting data on the benefit of IMC irradiation. And the second one is that when we treat these lymph nodes, there is sometimes increased radiotherapy dose to the underlying normal organs, including the heart and the lungs. So I'm going to present the most recent contemporary studies on the use of internal memory chain radiation therapy. And these are the French trial, the Danish breast cancer cooperative group trial, and finally the Korean radiation oncology group trial that is the most recent. So the French trial was initially published in 2013 by Hanneken et al. This is the study design. So it was a randomized phase 3 trial. It included around 1,330 patients with stage 1 and 2 breast adenocarcinoma, status post modified radical mastectomy. Adjuvant systemic therapy was given as indicated, whether it was chemotherapy or hormone therapy or castration. And inclusion criteria included patients who had positive axillary lymph nodes or patients who had a primary tumor that was medial or central located in the breast. Now, all the patients received adjuvant radiotherapy to the chest wall and supraclavicular lymph nodes using 2D planning. And the randomization was whether to treat the IMC chain, and the number was 670 patients, or not to treat the IMC chain with around 660 patients. Now, the primary outcome was overall survival at 10 years. The secondary outcomes were disease-free survival and toxicity. Now, the results of the study were disappointing, for there was no benefit from IMC radiotherapy. As we can see, the 10-year overall survival was 62.6% in the IMC arm versus 59.3% in the no IMC arm, with a p-value of 0.8, non-significant. The 10-year disease-free survival was 53% versus 49%, again, non-significant. Now, the conclusion and shortfalls of this trial are the following. So this French trial showed no difference in overall survival with or without IMC irradiation. The problem with this trial that about 25% of the enrolled patients were node negative, and hence this might have diluted the potential benefit of IMC irradiation. And finally, the use of 2D planning may have underestimated the coverage of the IMC lymph nodes, especially that there was no quality control of radiotherapy in this trial. Now, the second trial is from the Danish group. It was a population-based cohort study on the effect of IMC lymph node irradiation in early node-positive breast cancer. It was published in JCO in 2015. So this was a nationwide, it was prospective trial. It was one of the largest trials ever published for IMC irradiation. It included around 3,100 patients with early stage node-positive disease. All patients had surgery followed by systemic therapy as indicated, and they all received adjuvant radiotherapy to the chest wall or breast, plus supraclavicular lymph nodes. Now, the design of the study was as such that patients with left-sided disease were not offered IMC irradiation to protect the heart, whereas all the patients who received right-sided radiation therapy were treated to the internal memory chain. The numbers were actually almost the same, of 1,500 in each of the arms. The primary endpoint was overall survival. The secondary endpoints were breast cancer mortality and distant recurrence. Now, the study was positive in terms of improvement in oncologic outcomes, including overall survival and breast cancer mortality. So the 8-year overall survival was 75.9% in the IMC irradiation arm versus 72.2% in the no IMC irradiation arm, with a significant p-value of 0.05. Same as for breast cancer mortality, it was less in the IMC arm, 20.9% versus 23.4% with a p-value of 0.03. Now, there was a trend for lower distant recurrence, but it was not statistically significant, 27.4% versus 29.7%, with a p-value bordering significance of 0.07. In terms of toxicity, similar numbers of patients died of ischemic heart disease in the two groups, so there was no difference. So this trial actually was one of the first that really showed that treating the IMC lymph node chain would improve the oncologic outcomes, and it's the one we mostly use in nowadays practice. Now, they also did an explorative subgroup analysis in the study, and it favored the use of IMC irradiation in 3 subgroups of patients. And this mainly included patients who had primary tumors located centrally or medially, and for patients who had 4 or more positive lymph nodes. Now, the most recent trial is from the Korean group at the KROG 0806. This randomized trial was published in JAMA Oncology in 2021. It is the most recent. Now, it was a multi-center phase 3 randomized clinical trial. It accrued patients from 2008 till 2020 in 13 hospitals in South Korea. It eventually enrolled 735 women with pathologically confirmed positive breast cancer after breast-conserving surgery or mastectomy with axillary lymph node dissection. Nearly all of the patients received systemic chemotherapy, taxane-based, and eventually patients were randomized to receive radiotherapy, either with IMC irradiation or without. The primary endpoint of this trial was the 7-year disease-free survival. Secondary endpoints included the rates of overall survival, breast cancer-specific survival, and toxic effects. And these are the results. Overall, the study was negative, for there was no statistically significant difference in the 7-year disease-free survival for all the patients. For those who received IMC irradiation, it was 81.9% versus 85.3% for those who did not. Now, an ad hoc subgroup analysis for patients who had mediocentrally located tumors, there was a significant difference. For the 7-year disease-free survival rates were 91.8% for the IMC arm versus 81.6% for the no IMC arm, with a significant p-value of 0.08. Breast cancer mortality was as well better in the IMC arm, 4.9% versus 10.2%, with a significant p-value of 0.04. Finally, there was no differences between the two groups in the incidence of adverse effects, including cardiac toxicity effects and radiation pneumonitis. Now we will move to the management of patients who present with clinically involved IMC lymph nodes, as I show in this slide. So most patients nowadays are having PET-CT scan for staging, especially those with node-positive disease. And we can see in this case, a small internal mammary chain lymph node on CT scan, and it is quite avid on PET-CT scan, as we can see. Now, those patients are usually managed with neoadjuvant systemic therapy, followed by surgery. And upon referral for adjuvant radiation, we can see on their CT simulation plans that most of them have response in their initially involved IMC lymph nodes. Some of them have partial response, some of them have complete response, especially with those with HER2 positive disease. And usually when they treat them with adjuvant radiotherapy, we always treat the internal mammary chain, obviously. And we usually give a radiotherapy boost to the involved lymph nodes. And the dose is usually between 60 and 66 gray in total. Now, the best data on this comes from MD Anderson in a trial published by Zhang et al. In the Red Journal in 2010. That was a retrospective review of 809 breast cancer patients diagnosed with advanced nodal disease those with clinical N2 and N3, who received radiotherapy at MD Anderson from January 2000 till December 2006. In this trial, around 14% of the patients had clinically positive IMC lymph nodes that was detected on ultrasound, MRI, CT scan, or PET CT scan. All those patients were treated with neoadjuvant chemotherapy. And this resulted in a complete response on imaging studies in 72% of all the patients. And then patients eventually were treated with radiotherapy to the breast or chest wall, as well as the regional lymphatics, including the IMC chain. And the dose was 60 gray if the lymph node has completely responded, or 66 gray if the response was partial. And here are the results of the study. The 5-year IMC lymph node control was around 90%, quite impressive. The 5-year locoregional control was 80%. The 5-year overall survival is 76%. And finally, the 5-year disease-free survival was 56%. Now, moving on to the current radiotherapy techniques that are usually used for the treatment of IMC lymph nodes. The two most commonly used are one called the white tangent fields, and the second one is called the matching electron IMC fields. So if we look at the one on the left side, in green, this is the field that we use to treat the breast, which is called tangents. And here in orange, this is the field, the electron field that we use to treat the IMC lymph node chain. On the right side, we see the technique that only uses tangents to treat at the same time the breast and the IMC lymph nodes. Now, here's an example on a case where it is more preferable to use the white tangents. Here in green, you can see the radiotherapy beams, the tangent beams, that at the same time will treat the breast and the IMC chain that is here in green. Now, in this case specifically, we can see that the heart is quite far from the target. And this is why we prefer to use the white tangent field in this case. Whereas in this case, you can see that the heart is close to the chest wall. And if we want to use the white tangent fields, the heart is going to be inside of our beam, and it will probably cause increased toxicity for this patient. So this technique is not favored in this case. Here you can see that if we use this technique, we will be treating the heart and the left anterior descending coronary artery. So for this case, the more preferred option is the junctioning electron fields. And in this case, we use, here in blue, you can see the electron beam that is given anteriorly to treat the intermammary chain lymph node. And eventually, when we look at the radiotherapy plan, you can see that the radiotherapy dose goes around the heart and protects it way better than the white tangent fields. I'm not gonna do more techniques. This is too much, I think. And by this, I conclude my presentation. So in conclusion, adjuvant radiotherapy is indicated for most patients with node-positive breast cancer. Radiotherapy is delivered to the breast or the chest wall, the supraclavicular lymph nodes, and IMC for most patients with node-positive disease, as long as treatment can be safely delivered. The treatment of IMC lymph node is mostly beneficial for patients with N2 and 3 disease, as well as those with a primary tumor that is mediocentrally located, as we showed before. Now, patients who present with involved IMC lymph nodes require neoadjuvant therapy followed by surgery and then adjuvant locoregional radiotherapy. We usually give 50 gray and 25 fractions to the breast and lymphatics, and we give extra radiotherapy boost to the involved IMC lymph nodes, 60 gray if complete response, 66 gray if partial response. And finally, multiple contemporary techniques are used for IMC irradiation with the goal of accurate targeting of the IMC chain and maximum sparing of the organs at risk. And by this, I thank you for your attention.
Thank you, Dr. Bassem, for your comprehensive presentation. Dr. Bassem, I love to ask you about the deep inspiratory breath hold technique. which is the preferred technique to sparing the heart and providing a beautiful cover for the IMC lymph node.
So your question is about DIBH, the use of DIBH?
Yes.
Yes, absolutely. So at our department, whenever we are treating left-sided breast cancer, we always use the DIBH, which is, as you mentioned, the heart is pulled posteriorly away from the radiotherapy fields. And in many of these cases, we are able to treat the breast and the IMC chain using white tangents. In some cases, the patient's anatomy does not allow the use of white tangents, despite the use of deep inspiration breath hold. And this is when we tend to use the matching electron fields. But absolutely, if this technique is available, we should always use it for left-sided cases. Unfortunately, it's not available in all the centers in Lebanon, especially the centers in the periphery. You can only find it in big institutions, and it's definitely indicated.
Yes. Thank you.
We have questions in the box, please.
Yeah, there is a question about the using adjuvant axillary radiotherapy as a substitute for axillary clearance.
In which setting? For patients who present with
the benefit of using adjuvant axillary radiotherapy as a substitute for axillary clearance. The question is not.
I think in case of a positive sentinel lymph node instead of axillary dissection.
Yes, maybe that's
okay.
the yes.
Okay, sure. So for patients who initially present with clinically negative lymph nodes, but are found on sentinel lymph node biopsy to have positive disease, so the standard of care has shifted from axillary lymph node dissection to radiation therapy, and this was shown in the Z11 trial and in the MA20 trial. So when radiotherapy was used instead of axillary lymph node dissection, the risk of axillary recurrence was as low as 1%. So for those patients, we have stopped doing axillary lymph node dissection, and instead we treat them with radiation therapy. Now, in this setting, there is different practices. Some people are using radiotherapy to the breast only, as was actually done in the Z11 trial. And some patients are treating the undissected axilla, which includes level 1 and level 2 and the supraclav. Now, the bulk of the literature is to treat the breast only. I personally do it if there is 2 positive sentinel lymph nodes in young patients. In these cases, I tend to intentionally treat the undissected axilla. But for usual cases, only 1 positive lymph node, it is safe to treat the breast only as per the Z11 trial.
Very nice information.
Yeah, so
Yes.
I think also the updated result of Amaro's trial also shown the same benefit in randomized, well-randomized controlled phase 3 trial.
Absolutely.
So the cut point, Dr. Bassem, is 2 positive lymph nodes?
So positive sentinel lymph nodes, yes, 1 to 2 positive lymph nodes are allowed. If 3 positive lymph nodes or more are detected, then the standard of care is still nowadays to perform an axillary lymph node dissection.
Yes. There are other questions about hypofractionation doses. Is there any recommendation regarding EMN irradiation with hypofractionation dose?
Yeah, that's a very good question. So just to explain the difference, the standard fractionation, the schedule that is historically given, or the dose that was historically given, is total dose of 50 gray that is given in 2 daily fractions. Now, recently, especially coming from the UK, there was the use of hypofractionated radiotherapy, which entails the use of higher dose per fraction, which is around 2.6 gray. And by doing that, the number of radiotherapy sessions has dropped from 25 to 15 or 16 instead. And this was shown to be less toxic. So the cosmetic outcomes were better in the hypofractionation arm. And definitely it was more convenient for the patients. Instead of coming to the department, to the radiotherapy departments for 5 or 6 weeks, the patient now can come for 3 or 4 weeks. Now, the bulk of the data is in node-negative disease. Up until recently, where a randomized trial done in China showed that it can also be used for node-positive disease. So at our department, we do it safely for those who require treatment to the breast, chest wall, and supraclav. Now, if the patient requires treatment to the internal mammary chain, we do it if the white tangent technique can be used. But if the junctioning electron fields is to be used, we don't use it because we still fear toxicity on the heart and lungs. Apologies if this is too much technicalities, but this is the best I can do.
Dr. Bassem, we adapted the hypofractionation schedule in Iraq since 2014 because the paucity of the radiotherapy vacancies on the machine. We adapt the hypofractionation for the breast, and all the data that we have is similar to the traditional schedules.
Why you do not publish it retrospectively?
I fully agree.
Hey, Dr. Haidar, it's very interesting to publish it retrospectively. If you have a big data like this, it will be nice.
I have big pool of data. Just in our center, we have more than 1,000 patients through the last 8 years have been treated with hypofractionated schedule.
Good.
I try to collect the data and waiting the result of 5 years survival and progression-free survival for them, because some of them doesn't reach the 5 years till now.
Yeah, I think it's totally safe and effective. We also in Morocco use it for economical issues for the patients and for the access to the machines. Unless some cases, as you said, when you have some technical limits. Absolutely. I think that we answered all the questions in the... Yes.
So thank you, Dr. Bassem. Let's go for the last lecture. Dr. Lalla.
Yes, I'm sorry, I came late, so I don't know exactly what I should do. Sorry for that.
No problem. You have to. So I can go directly to the program. First of all, I would like to thank everybody. The invitation were really with short notice, and this is because of many things. Dr. Tahsin and Dr. Alala, Dr. Haidar, Dr. Bassem Youssef really supported us quickly. Thank you very much. Dr. Sami Khatib is always with us, so there is no problem. He's always ready for us. I would like first of all to answer the question on the previous presentation about the response of everolimus in ER negative. We do not have answer because it's mainly act when the ER positive is active and is present, and it should be aligned only for ER positive patient. The second question is about the most frequent toxicity of alpelisib, or the most serious, really indeed it's the diabetes. So the diabetes, the control of glycemic FBS is the most important or most frequent to be done. But again, it's manageable. So now I will share my screen and I will be presenting the next my presentation, and somehow I lost the title. Okay, so the title of the presentation is the prognostic and predictive value of intrinsic subtype for overall survival in metastatic breast cancer. Indeed, the Mona Lisa team did an analysis on all the Mona Lisa concerning the intrinsic subtypes. And just to say that, first of all, I will start by answering the question of Dr. Tahsin Al-Ribai about overall survival. Indeed, for a long time, we haven't seen any progress in, we haven't seen any progress in the overall survival of breast cancer. And the only progress was with the Cleopatra trial in HER2 positive, where shown there is a overall survival benefit. So despite the fact that we have new drugs, the impression of doing better, remember the overall survival benefit was stuck to the 3 years, almost approximately 3 years, for a long time. And the arrival of CDK inhibitors, as you can see here, gave us really a benefit, the benefit of improving overall survival. And you know very well that there is many trials, the Paloma, the Mona Lisas, and the Monarchs trials. So the Palomas with S, Mona Lisa with S, we have many trials, but of these trials, we can see that some of these trials, the Paloma 2 and the Monarch 3, are still, results are still pending. And we know very well that their results are not yet here, but this, even if we cannot compare different trials, we can say that we have 3 Mona Lisa trials, the 2, 3, and 7, and 1 Monarch trial, the 2, showing an advantage in overall survival and overall survival benefit. And the hazard ratio is 70 almost. So it's 25 to 30% decrease on death. So these 4 trials, and the 5th, and let's here just show that in this presentation, you can see that the needed improvement as per ASCO should be 20% improvement in OS in order to say that it's clinically manageable. Remember on the Bell trial, we said that it was positive, but clinically not meaningful because of toxicity or because it's not reaching this level. So a 20% improvement at least. And these trials responded to this criteria, as you can see. The Mona Lisa 237 and Monarch really responded to this criteria, while the Paloma trial, unfortunately for our patient, didn't respond. Because as you know, more drugs we have, more approval, more beneficial for our patients. So again, if we see it this way, we have really an improvement and a colossal improvement in the Mona Lisa trial, in the Mona Lisa 7, 2, and 3, and in the Monarch, but not statistically enough significant or nor clinically manageable for the Paloma trial. So why do we have that? Is it because these drugs are different? You know very well that for a long time, the debate was, are these drugs the same? It's simply a class effect, or these drugs are different. First of all, we have to know that these are CDK4 and 6 inhibitors. And we know that this CDK4 plays more important role than the CDK6. And we know that the ER positive breast cancer cell, as you can see here, in red, we have more concentration of CDK4, while in the hematopoietic, more CDK6. Remember, this explains somehow the toxicity by having more hematotoxicity in the CDK4. And remember that the CDK4 usually is associated with endocrine resistant. And here it was shown in the Paloma trial that this line for the patient with high CDK4 level, the addition of palbo really was not impressive, while for the low, as you can see here, for the low expression, the addition was impressive. So this means that when you give the endocrine therapy alone without the CDK, the high expression of CDK4 is a prognostic. So again, I repeat it. When you have a CDK4 expression high, the endocrine therapy by itself is not enough and the prognosis is bad. So if you have it low as in this curve, the endocrine therapy by itself is sufficient. And if you give CDK inhibitors in both high and low, you will have an improvement. This is just to show the importance, the prognostic indication of CDK4. And now we can see that CDK4 inhibitor have differential activity against the two targets, 4 and 6, while the palbociclib, showing here that with CDK6 and CDK4, you have almost the same inhibition. You can see very well that the ribociclib is inhibiting what's in red, is inhibiting more the CDK4 than the 6. And here the ABEMA also doing the same, inhibiting both the CDK more than CDK6. So again, so we have that the CDK is more present in cancer cells, and we have that the CDK4 more in breast cells, and has a prognostic indication. And also we know that ribo and ABEMA will inhibit more the CDK4 than the CDK6, and this is probably one of the reasons explaining why these drugs are acting differently on the breast cancer cells. You see ribo ABEMA more CDK4 than 6, palbo equal for both. And you know that the ribociclib has really a more level of exposure in plasma than other CDK. So this also might be one of the reasons. As you can see, AUC 024, it's more than 20,000 compared to 5,000 or 1,000. And this also is an important reason why we probably had reached an overall survival benefit when adding ribociclib to endocrine therapy in 3 and in all Mona Lisa, because there are 3 and the 3 positive trials. And that's also why it's efficacious probably in first line and second line, in different indications, and a different outcome as even PFS2. So you know that the PFS2 also has been rich in all these trials and also in ribo, and probably that's why also these medications are active, and specifically the ribo, in different metastatic sites. And important that also in bone alone metastasis, this drug is beneficial, and should say again that for all site of metastasis, there is a benefit, overall survival benefit for the ribo. So I will skip this slides, just showing that the overall survival maintained independently of chemotherapy. And I will go to the slide and saying that even if we cannot compare, since it's not head-to-head, again, we are seeing overall survival benefit in the 4 studies, but not in all, which means probably that it's different drugs. And I will try to explain, we went through the basics by explaining about the CDK4 importance as a prognostic marker, the CDK4 presence in the breast cancer cell, the CDK4 inhibition more with ribo and abema. And finally, I will go here through the usual pathway that we used. Usually, when we have a breast cancer hormone positive, we look to the histopathology, we look to the clinical finding, and we make our decision about the treatment. And we always knew that there is something missing, and we knew that what we call the driver of the disease is different between these drugs, since even ER/PR positive in some cases did bad. And then we started learning that there is a molecular classification, that molecular subtypes that should be taken in consideration. And we learned that there is what we call intrinsic subtypes. So I want today to emphasize on that. And I want to say that the histopathologic marker usually, when we started the treatment for people, old people like me, we used only the ER/PR to treat patient. But then after the HER2, and we had different diseases, we had different subgroup, HER2 enriched or hormone positive or triple negative, and we used the adequate treatment. But now we are using more if you use the gene expression, we know that there is 4 categories. Remember, the luminal A, B, and HER2 enriched and basal-like, it's a molecular classification and not clinical or histopathological. While usually we say luminal A, but it's not really right to say it when you talk about pathological or histopathological classification. And we know that between luminal E and B, there is a difference in incidence and the prognosis and sensitivity for treatment, and also between HER2 enriched, basal-like, and all luminals. And this is due mainly to the presence of genes. And we know that in luminal A, B, and HER2 enriched and basal-like, I will not go through the 3 others. We know very well that the presence or absence of some gene, selected gene, will say that this is the subtype, the luminal intrinsic subtype, luminal B or A or basal, etc. But now we are understanding that it's more complex, because when we go for the classification by histopathology, we say that for the ER positive, HER2 negative, if we go for the intrinsic, for the molecular classification, we observe that there is almost 15% that are not really, as we call, luminal. So there is 15% which might be different than ER positive. You can see that we have normal-like, we have some basal-like, and we have some HER2 enriched. So the question is this: the reason why some of our patients are not responding very well, or are not responding at all, or are resistant to hormone therapy while they are expressing the ER positive. So now we are trying to understand that, and we can see that even in some triple negative breast cancer, ER negative, PR negative, HER2 negative, we might find some luminal A and some luminal B. So we might find some patients probably sensitive to the hormone therapy, and also in the HER2 enriched disease. So the intrinsic molecular classification is leading in the understanding of the subtypes of these histopathological classifications. So while usually we had the pathological, and now we have the intrinsic. But remember that these classifications are different because we are detecting different, we are searching for different targets. while in the pathological method, we are talking about the IHC or the the hybridation, IS hybridation. Remember that here we are checking for the HER2 protein expression or the gene amplification. While if you detect or to trying to classify by the molecular testing, you are checking for the genes, as I showed you previously. I will go through it. So it's about, sorry. So it's about genes. When you talk about intrinsic classification, it's the presence or absence of different genes. So again, I will tell you, I will remind you that the pathological classification is based on the search of the protein expression or the amplification of the gene, while in the intrinsic, it's about the searching some specific gene. And here you can see that in one of the analysis, and I think it was they could show that the HER2 enriched has a worse prognosis when treated with adjuvant tamoxifen alone, and even the overall survival when based on intrinsic subtype for those treated with letrozole and plus minus lapatinib was worse. So yes, these patients are not responding to endocrine therapy when they are HER2 enriched. And in the Mona Lisa trial, the 3 trials, the pooled analysis, which is a big number of patients, they found that if they do the intrinsic subtyping for the ER positive, HER2 negative, they will find almost 15% of HER2 enriched, which in my opinion might explain the resistance on some tumors. And we have some basal like 3%, while the majority are luminal A or B, fortunately. And in the pooled analysis of the Mona Lisa trials, the intrinsic subtype seems to be a prognostical factor for overall survival and PFS with ribo and ET. So look to this slide. You can see that for patients treated with endocrine therapy alone, when the patient had a luminal A or B, he was doing very well. Remember, all these patients are ER positive, HER2 negative, are pathologically ER positive, HER2 negative, and by the intrinsic classification, they have luminal A or luminal B. So if you treat with endocrine therapy alone, the HER2 enriched will do really bad compared to the others with, and the BASA the same. And also for the survival, the PFS and OS were worse in the case of endocrine therapy alone, which means that these are not sensitive for endocrine therapy. But if you give the CDK in addition, you will get results. Look to this slide. These patients in luminal A had really a good benefit when they get ribo plus endocrine therapy. Those who are placebo got benefit, but less with a difference. So in luminal A, ribo will improve ribo will increase the efficacy of endocrine therapy. And in the Mona Lisa trial also, the ribo in luminal B will increase. And even in HER2 enriched, I will go back to the last slide. Remember that if the endocrine therapy is given alone, the HER2 is doing bad. But if we are adding ribociclib, so there is a result. And the most important, look, in the basal, even the addition of ribo will not help. So this means that the HER2, in the HER2E subgroups, the ribociclib might overcome the resistance to endocrine therapy. And this is a very important and a new, element to understand in our practice. So in the pooled analysis, ribo was active in all subtypes A, B, HER2 enriched. Look the difference. but not the basal-like. My wife is calling, guys, from Canada, so I have to show her that we are working. Thank you. And the overall survival benefit, when you add the ribo, is giving a good difference, but not in the basal-like. And it's amazing here to see that the HER2 enriched, we have a substantial benefit, 40% decrease of the death, which means for some reason, these subtypes of ER positive, HER2 negative, HER2 enriched by molecular testing, they are getting better response. While does other CDK4/6 inhibitors show the same? No. We can see here that the Paloma 2 and Paloma 3 couldn't show an important improvement in the by the addition of Palbo under for the endocrine therapy compared to endocrine therapy alone. So I'm really trying here to reach a principle that this difference in the action of the drugs might be the reason why we have different results in these trials. Remember again that the differences in PFS benefit with Palbo by intrinsic subtypes was there, but not the overall survival. Okay. And here are real-world data showing that the HER2 enriched have really a poorer prognosis. So we have a poor prognosis, and we can overcome it while giving the ribociclib, but not, unfortunately, but not the palbociclib. Again, look to the curves, luminal A and luminal B. No real improvement when adding this treatment, palbociclib. And I like the slide, and I think it's important because the luminal B and HER2 enriched xenograft have a greater response to ribo than basal-like xenografts. Look, again, really a nice suppression. And this is important to understand the mechanism, really the basics of it. We know very well that we have now estrogen activation related genes like ESR and others. We are talking a lot about ESR. The ESR is an estrogen activated related gene. So the upregulation of these genes will lead probably to response. Okay. And we know that we have proliferation related genes, and the downregulation will lead to also a control of the disease. Apparently, the ribociclib can upregulate the ESR1 gene and downregulate the proliferation-related genes. And this is shown in the next slide. While we know very well that in the normal breast cancer tumors, I almost finished, we have some shift from basal-like or from HER2 to different subtype, to different also subtypes. We have luminal A transforming into luminal B or basal or HER2 enriched, etc. We can see that when we add the ribo, we probably have a down or a switch from HER2 more to the luminal subgroups. This what might explain the reason. So probably there is a biological shift from subtypes to another, explaining the results with ribociclib in this meta-analysis. So it's a pure scientific data. And very nice trial that we will be waiting. It's the phase 3 Harmonia study, in which we will have two answers. I will go for it later. So for ER positive tumors, we will select the intrinsic subtypes HER2 enriched and basal-like. For the HER2 enriched, we will stratify to receive ribo or palbo, and we will answer the question, is ribo and palbo the same in this subgroup of molecular breast cancer? And we will take ctDNA in the beginning at the second cycle and at the progression to see if there is really a shift from a subtype to another, from HER2 to another subtype. So two questions, two answers. What are the comparison, the results of Ribo to Palbo in HER2 enriched, which is superior and which is inferior, or are they equal? The first question. The second is really, is there any tumor biology shift from the one subtypes, which is the HER2 enriched, to another subtype? And with that, I finish my presentation. And I think these are a backup slide. I'm sorry for that. I finished my presentation here, and I give the floor to the panelists. Thank you very much.
Thank you, Dr. Professor Fadi, for this very nice presentation, talking about some explanation for why some drugs are not working while she was supposed to work. So there are no questions in the Q&A. I am asking the panelists, do you have some questions for Dr. Fadi?
I think they are tired now after 1 hour and a half,
Yeah.
2 hours.
Yeah, and the lecture was very clear. So,
Yes.
so if you allow me just to thank all of you, Dr. Fadi, Dr. Lala, all speakers and moderators of this session. I would like to thank also all our participants. So it's almost now we have 73 participants with us online. Just to mention that we are waiting for you next Tuesday, March 29th, that we are going to talk about the GU modules. Thank you all and good night.
Thank you. See you next week. Thank you for all moderator, attendees and speakers, and Dr. Sami, and also Science Pro, who is really supporting us nicely. Despite our تأخيرنا, on est toujours en retard. Merci beaucoup et au revoir.
Thank you, everybody.